Пожалуйста, следующий доклад. Chi-Kong Lee.
Now we have the next presenter, Chi-Kong Lee, Perspectives of multicenter collaboration in Asia on pediatric hematology and oncology in Asia.
Ladies and gentlemen, the previous few speakers talking about the clinical collaborations in the global manner. But how about in Asia? Now, I would like to share with my views and experience in the past 20 years in the clinical trials and the multicenter trials that has been done in my country and also internationally. Now, firstly, when we talk about multicenter collaboration, we all agree that this will improve the clinical outcome by sharing of the knowledge, skill, and standardization of the diagnosis, the treatment, protocol-driven approach, and for all participants, they all have this learning process. And finally, we need to have a good quality of data collection, analysis, and interpretation. Now, the requirement for this multi-center collaboration, firstly, we must have a common goal shared by all the involved parties. Why we have to do the multi-center collaboration is that just for improvement of quality and improve the cure rate, or we have some research questions we want to ask, or you want to have a better influence on the government policy. And secondly, we must have the dedication for the collaboration because you require extra time, effort, and resources to make the collaborative studies successful. And it is also essential that the participants can communicate efficiently among themselves. So language is one of the important barriers in some of the collaboration. Other than that, we also need to have some meeting platforms for people to meet face by face. And then later on, they can further communicate through the electronic means. And finally, for having these multi-center collaborative studies, it also requires some additional resources. We need extra manpower, and the logistics on sometimes may require new drugs and the facilities and equipment. Now, for some countries, they are really having huge population like China, India, Indonesia, and Pakistan, is having more than or approaching 200 million. Now, with that kind of a patient load, they should be able to conduct large-scale national studies to answer some specific research questions. Now, if they are doing national studies, they have the advantages of using the same language, having a similar culture, similar economic and social background. Even though sometimes in some big countries, there may be great variation in these factors within the countries. But at least there is a more easy travel and a shorter distance, and we don't need to apply visa to visit to these centers. And the national societies may organize the national studies. Now, just take one example for Japan. I borrowed that from Japan. That for Japan, they have the population of 120 million population with leukemia incidence of about 600 to 800 new cases per year. But when we look at the history of collaborative studies over the past several decades, firstly, in 1969, the Tokyo group formed the study group. And then in the 80s, there's the Japanese leukemia study group. And then the Kyoto group also formed in 84. And in 96, another study group formed. But finally, is in 2003, they formed a uniform Japanese pediatric leukemia study group. So it takes 20 years. Now, they actually, among all these study groups, they have been working very hard and producing very fruitful outcome on different types of studies. You can look these different names of the study groups. But finally, they formed jointly the study group, and then also recently also working with all the other cancer groups to form the Japanese children cancer group this year. So for organization of the national groups in big countries at the start, like the Japanese experience, there may be several regional groups in one country. Even in United States, also start with the POG and CCG, and only in year 2000 they formed their children's oncology group. In China, we are also seeing similar study groups forming in different regions. So for different groups within one country, there will be competition, but we also see collaboration. As times go by, when these groups recognize the need for integration due to various reasons, they may then decide to form a large national group. But forming these kind of study groups, we need to have leaders in the study groups. They are pivotal to the initiate. And more important is to make it sustainable, to maintain these working groups to continue. And finally, we also need the joint effort to apply the research funding from the government, from the charities, and other NGOs. Take one example in China. This is a study participated by 10 hospitals with 2,200 patients over the period of 2008 and 2012. And this is called the CCLG 2008. But there are also other study groups now initiated called the China Children Cancer Group 2015 with 18 sites, and then with 1 year is having 1,200 patients recruited. So it's about 1,000 patients per year. And in South China, there are also similar groups. Firstly, start in a city called Guangzhou in 2002, and then in 2008 in a provincial study involving more cities, and then they are now studying on the South China 2016 study, and the protocol is now drafting. So with these many different groups, but when we look at China, it's estimated to have about 6,000 cases per year. Even all these groups I mentioned is probably just cover about 1/3 of the patients. That means 2/3 or half of the patients with ALL are now not included in this kind of clinical trials. So that is the room for improvement, even though there are already some study groups in place. In Russia, you have already listened to the talks about the MB studies, and they are also not only MB2002 and the MB2008, and then now the new 2015 studies are also ongoing. So there are many different countries having their work on this collaborative group. And when I look at what about the other smaller countries? Actually, Pakistan is not small, with the population approaching 200 million. They are also starting to have this prospective study, but they are just firstly looking at something simple, the clinical features and induction outcome on still a smaller number of patients. And for Saudi Arabia, also having a retrospective studies at institutions looking at some of the clinical outcome. So for countries with a smaller population, initially they may aim at just looking at unify the treatment protocols, standardize their treatment methods. Later on, they may collaborate with some advanced centers in the country or in the overseas centers for centralization of new diagnostic and monitoring tests. For example, MRD studies, genetic markers, MTX monitoring, or TPMT or NUDT15 testings. However, we have to emphasize that the design of these studies must suit the local situation. They can test on innovative approach according to their local situation, and then aim at improving the outcome. But joining international studies certainly can help these centers to learn how to conduct the clinical trials. So I also noticed that there is actually more collaborative work now ongoing in this called the MECA studies in a prospective study involving 14 Middle East countries. Each country is probably small in population, so that they, over this period, about 1,100 patients recruited. But in this study, the importance is that not only the local participation, but also with another 5 institutions from Europe and North America participated in that study, in the design of study, the conduct of the study. They initiated the electronic submissions of data via the web-based approach. So the minimal collaboration studies have some successful example, as I talked earlier this morning about the Singapore-Malaysian study. They used the de-intensification approach by the MRD guided treatment. And with 4 centers over nearly 10 years, they recruited even a smaller number of patients, just about 556. But the outcome is really excellent. So this actually demonstrated this regional collaboration, having a center as the data center, central laboratory, they can be very successful in having improvement in the outcome. So that is the result that is reported by Eden Yo a few years ago in JCO. But there are some barriers of forming the multicenter studies. Firstly, there may be differences in the views in the participants. Some may favor the American, some may favor the European, or they may hope to have the Asian approach. And another barrier is the lack of organizational experience and expertise. And we need to have a strong leadership to maintain the cohesiveness of the participants. And also we have to establish trust among the members, and the powers and benefits has to be well balanced. And the lack of resources is certainly one of the great barriers. I would also like to use one international trial example to demonstrate how we can move forward. The ICBFM 2002 studies, which is actually the largest multinational studies, with more than 5,000 patients enrolled from 130 centers from 15 countries. Most of these participating centers are from the IBFM members. And however, the leaders, including from Germany and Italy, and they gave advice on the study design. So the countries involved, including the Eastern Europe, the South American, and also some Asian countries. And they meet regularly in the IBFM meeting at least annually. And they designed a study tailored for treatment according to the resources they can do. So it's a non-MRD-based study. So this has been reported in the JCO just two years ago. Now what happened to these successful collaboration is that after the completion of the 2002 studies, there are some centers, actually they had more advanced development, like the Czech Republic and Israel. They moved to forming the formal SIOP BFM 2009 study. But majority of the groups stay behind, and also with 4 new countries joining the new 2009 study. Now for Hong Kong, we moved away from the IBFM because we want to have more work in our home country in China. So we actually involved in the CCL G208 and CCC G2 2015 studies. So with this way, we actually seeing the experience of the international clinical studies can now be shared to more centers, and then we may be able to establish more clinical trials according to your own country's situation. So the way forward to this multi-center collaboration is to, firstly, we have to have sharing the mission of improving the survival of cancer children. We need to create platform to meet, to understand, and to discuss, and start with projects with common interests. So for example, recently we have under the platform in the St. Jude River platform in Singapore, there's a new study is now on the planning process, that is the River Asia Down Syndrome AL study, including China CCCG, the Japan JPLG, and the Singapore MASFO, and the Taiwan TPOG. We are now developing the research protocol to deal with this uncommon disease with suboptimal outcome. That is the way how we move forward. So finally, I would like to thank you for your attention.
Спасибо.